stroke and it's not clear, we tend to do a non-invasive cardiac monitor, like a Zeo patch or something, for a couple weeks. And then, if that doesn't show AFib, we go and send the patient to the cardiology clinic for an interventional cardiologist, or I guess the arrhythmia cardiologist, to insert this cardiac monitor subcutaneously. It's a little device like this, and the patient wears it for a minimum of 6 months, at mostly 3 years until the battery dies. And then they gets interrogated every month to see if there's AFib detected. So we jump from this to this, which has its own costs. And it's important to look longer. In a cohort of ESUS patients where the cause was unknown of their stroke, at 3 years of follow-up, AFib was eventually found in a third of them. So we know that there's a big unmet, undetected group. But is there a better way to do this? Most patients have been fine with getting this thing inserted in them, but is that really the best way? Before we get back into that, some people just say, why monitor, monitor, monitor? Why not just treat empirically with anticoagulation? I mean, you have this stroke, it's embolic. What else could it be? You did the workup, all that's left is potentially undetected AFib. And with the new oral anticoagulants that have less bleeding risk, maybe we're gonna see a benefit against bleeding in this new era. And so, should we just treat? How many of you guys do that? You treat empirically. Really? Oh yeah, shocked.
What do you treat with?
Treat with anticoagulation empirically in an embolic stroke of undetermined source.
Yeah, I work at the county, and there's lots of patients who can't afford the co-pays for LINK. And so if they have a chest tube score, it's above 5 or above 4, we will talk about doing it.
Okay, so the county, I saw all the county people that raised their hands. Like, they don't have access to this technology to get a LINK monitor. But they all have iPhones.
How about ESUS with a 1-month monitor that shows no atrial fib?
Yeah, so what's the right combination?
Aspirin and Plavix versus full anticoagulant?
No. Well, we don't do that in stroke neurology. We don't do dual antiplatelet therapy compared to anticoagulation after that active W trial that compared warfarin to dual antiplatelets in AFib and found that there was basically the same amount of bleeding risk without a better benefit. You might as well just put the patient on anticoagulation at that point. So unfortunately, actually, we are doing clinical trials in this area, which I run here, and the Navigate ESUS trial and Respect ESUS trial, which used rivaroxaban and dabigatran, they compared patients with ESUS. They had slightly different dosing, but compared to aspirin, this empiric treatment was not beneficial. There was too much bleeding. And so we thought that maybe we have way too many bucket of patients in these ESUS trials, and that we need to hone in on who are the patients that have these AFib-looking strokes. Is there some more data, some more biomarkers that we can then figure out who to treat? And so we now have the Arcadia trial running here and at other places funded by the NIH, which is taking apixaban compared to aspirin in patients that have an embolic undetermined cause of stroke and a biomarker for atrial damage or atrial cardiopathy, and it could be either a pro-BNP, it's like P-wave terminal force, something I learned about, an EKG change basically, or an enlarged left atrial diameter.
Diameter or volume?
They're actually using index, and I don't know why they didn't decide to use volume, but anyway, yeah.
I'm just curious where...
Dr. Westphal from the county.
Yeah, Jack Westphal, sorry. I'm just curious where thromboembolic strokes from septal defects fit into this.
So the PFOs and ASDs, so they're not included in the ESUS, so they may come into the ESUS category, so they're allowed to be in the ESUS category. And this ESUS category was created before the recent trials that showed that PFO closure can benefit patients for stroke prevention, but those patients were under 60. So I simplify this, these patients are older than 60.
Okay.
So back to this lady, she ends up with an ESUS because her 2-week monitoring has no AFib, and that's considered sufficient time to be not cardioembolic. So what did I do? I saw her in clinic. I said, we just finished the Navigate trial. There's no data for empiric anticoagulation. So if we're very suspicious of anticoagulation or of atrial fibrillation, in order to anticoagulate, you have to find the AFib. I don't empirically treat, and most neurologists don't do that either, because of our concerns for intracranial hemorrhage and other hemorrhage, which you can debate and argue. But our default plan is to refer the patient to cardiology for the link monitor placement. And then I asked her, as I usually do, to show me her home blood pressure log as part of my, cardiac risk reduction. And she showed me this, or something like this. I think it was your device.
Okay.
So she shows me some device, and it has all these blood pressures, and this isn't what it was. I just took this from the internet, but she had, some 140s, 130s, and then under 2 of the blood pressure numbers, it said irregular rhythm detected, or irregular rhythm suspected. And I was like, what is this? This is great. Does my patient have Afib? Because I have a high suspicion. This device, I'm a believer in technology, is suggesting something's going on. And I didn't say it, but in her Zio patch, she also had some, irregularities, but nothing that was definitive Afib. And like a light went off for me that I had a problem. I didn't know what this was, and I had to call Hattie and say, we need to do a meeting on this and figure out how can we leverage technology for better detection. So the U.S. Preventive Task Force says there's insufficient evidence to just be screening the healthy population. And I guess I would ask Jackie, how accurate is this tech in detecting Afib? Are we going to get a lot of false positives, increased utilization? How good is the technology? How does it work? And maybe you're not detecting, the U.S. Preventive Task Force is really focused on just healthy people, everyone, all the people. But what if we hone in on a subgroup of people? Patients with risk factors. Okay, which risk factors? Patients who've had a stroke or an embolic stroke of undetermined source? I mean, for sure, if that person has any second of Afib, I'm putting them on anticoagulation. And so, I don't know what I was writing here, but anyway. Or should we actually pick the CHADS-2-VASc? Anyone with 2 points on the CHADS-2-VASc score. So you take a patient with diabetes who's 65. Should we just give them a cardio monitor? Shouldn't they be having it? Why are we waiting for them to have a stroke? So how are we going to implement this? And honestly, the patients ask me, what more can I do, doc? How do I prevent myself from having a stroke? Even their spouses ask, he had a stroke, I don't want to have one. What can I do? So there's insufficient evidence, but what's the harm? When we recommend a pulse check, isn't having a rhythm monitor on your iPhone that's ubiquitous better? So Jackie, answer this question.
20 minutes, okay.
It's okay. So I just wanted to pose those questions. And remember the breakout question, which is how are we going to implement better detection and adherence to atrial fibrillation therapy in our clinics and in our institution?
Do I need this?
Yeah. They're recording.
Oh, they're recording it, okay.
So Jackie, do you still have to break at 6 o'clock and go do something else?
Yeah. Quick phone call.
35 minutes from now. Okay.
Thank you
so
for reminding me, I
have
totally
35
forgot
minutes.
about that.
Let's
It's like
forget
the
about
ACC,
it.
so that
We're
would have
getting
been
very
bad.
excited. Well, you've got 35 minutes, so.
We'll do it, and then we'll come back. So, it's nice to meet you. Thank you for having me. It's always great to be around all different types of people who are involved in a common cause because as I work at a 50-person startup and I'm the only clinical person on site, so I'm constantly reminded get out of your bubble. You're thinking like a cardiologist, think insert whatever job you want there. So it's always good to think about how people are thinking about the same sciences that we are.
So the agenda, and I will go quickly through the first part, but I wanted to talk about something called subclinical atrial fibrillation or silent atrial fibrillation because we spent a lot of time at AliveCor thinking about ways to prevent first stroke or the primary prevention. There's a lot of literature, particularly funded by Medtronic, for what you do after you have a stroke, if you're looking for a cause of your cryptogenic stroke. There may be a particular use case for an event monitor like ours, but we really focus on trying to prevent first stroke. So we'll get to a demo. Maybe Hattie will do the demo. I think she's better at selling the device than I am. So.
I love technology.
I know it.
I fell in love with it at an American College of Cardiology tech conference.
That's great. I love it.
I just think it's cool. I think knowing our own biometrics is just helpful.
We're not paying her at all. I just met her. Okay. Anyhow.
I swear.
So there There is a difference between what we call silent or subclinical AFib and clinical AFib. And one of the major reasons is that all the research for the last several decades has been done on symptomatic or clinical AFib. So we'll make a lot of jumps between, oh, we screen for AFib and you treat it, you're going to lower your risk of stroke. And that causal relationship, in fact, has not been proven. So there's a lot of extrapolation that silent AFib carries the same risk as symptomatic AFib, and that is not the case. So keep that in the back of your
Did you
mind.
say that is not the case?
It has not been demonstrated in our RCT.
Okay, in the randomized controlled trial.
That's right. So based on my back of the envelope calculation using the 2019 AHA-ACC statistics on stroke, there are nearly 200,000 strokes associated with AFib each year. And the way you get that is about 90% of strokes are ischemic, and there's an association with 1 in 4 ischemic strokes with atrial fibrillation. The caveat is that not all of those are necessarily related to a cardioembolic phenomenon. Some people think of AFib as kind of the harbinger of a systemic disease process, where you may also have atherosclerotic disease, and it may be true unrelated. So you might find AFib in a person with cryptogenic stroke, but the fundamental etiology of the stroke was in fact not cardioembolic. So there have been some studies that say that about 3/4 of strokes in patients with AFib are in fact due to a cardioembolic phenomenon, and then there's other etiologies. As Nirali mentioned, if you do more ECG monitoring, you're going to find more AFib. And this is great for our company, it's great for Medtronic and other device companies that are looking for more reasons to treat patients with blood thinners. If you have someone come in to the hospital with stroke, you can often find that 10% of people are presenting with AFib for the first time when they have a stroke admission. You discharge them with continuous monitoring or a looping event recorder like a implantable loop monitor, and you'll find that 15% have a diagnosis of AFib at 6 months, and then upwards of 30% at 3 years. As I alluded to before, we know through lots of literature that patients with AFib have a 5 times increased risk of stroke. The caveat there is that is clinical AFib. If you are diagnosed on a screening tool like Cardi Mobile, we don't yet have that established relationship between subclinical AFib and stroke. And as I referred to earlier, there are lots of studies in patients with pacemakers. So this is a selected group of patients. They've already had a pacemaker in for another reason. And we've detected, if you detect very brief episodes of silent AFib, the longer those episodes are, the more likely that they're going to have a stroke or death. And the greatest risk of stroke happens with asymptomatic episodes that are 24 hours or longer.
Asymptomatic, and it's going for 24 hours.
That's right.
Is it truly asymptomatic?
Yeah, people don't know they don't know that they're having these episodes until their devices are checked after the fact. Yeah.
I know when I'm having it. I mean, it's very uncomfortable
That's when
each
it's.
time, and I know when it goes away.
Yeah.
It just goes away, and boy, it's just this great feeling. So, I don't know if there's,
Well,
If you
I think
describe your-
anecdotally people will say that younger patients like yourself tend to be more symptomatic. Someone who is 80s or 90s, they may be less inclined to feel it, but
I would say in the past year, of all the patients of mine that came in with a stroke and had a new diagnosis of AFib, only 5% felt something. I would say the majority are silent. Yes.
So my concern would be for patients who have symptomatic AFib occasionally, how often do they have asymptomatic AFib?
I mean, unless they have an implantable loop recorder, we don't know.
yeah, that's a great question, because when I have AFib, I know it's, my pulse is normally high 40s, 50, and so when I get it, my heart's, it hurts.
Yeah.
And when it goes away, I'm assuming that I don't have any,
Burden of AFib.
I don't believe I have AFib when I don't feel it. And I've been on a Holter monitor 3 times, and my irregular heartbeat count is 1,800 or something for the day. It's pretty low.
Your PAC count, perhaps?
Yeah.
Well, it's,
whatever it is.
what you'll find is a lot of people you'll treat, and you give them something that slows their heart rate, like a beta blocker. And so they may have atrial fibrillation, and now they don't feel it. And so it's a misnomer to think that you're not having, misconception to think you're not having atrial fib, only when you feel it. And you
And
do
that's-
monitoring, you do AliveCor, you do
But
other ones.
I'm not
You find
talking
that they're
about-
having other shorter episodes you may not feel, and the heart rate just, probably just because it's slow.
I have avoided taking a beta blocker when I know I'm in AFib.
He's not on regular medication.
Yeah.
Well, I'm saying a lot of, I'm not talking about you, I'm
Right.
talking about other people, you'll have them on therapy, which tries to prevent these episodes, and you're not sure that they're preventing it because, just based on their symptoms.
Or they're on some of these other medicines for hypertension,
Right.
and so they never have a rapid heart rate.
Feeling mass.
I think it goes back to the point that it's about rhythm, not, rate control or symptoms, in the
Symptoms are not
majority of
always an
cases.
indication of the amount of atrial fibrillation burden to some extent.
So, let's go on.
Yeah.
So the basic framework for thinking about silent AFib is, are you picking it up before your first stroke, or are you picking it up after a stroke? And we'll go through that. So the previous presentation was a lot about what you do after someone has a stroke, and I will focus more on how do you prevent the first stroke from happening. So what are the reasons, what are the pros and cons for evaluating for silent or subclinical AFib? So I mentioned that there is a clear association between clinical AFib and risk of stroke. There's also an association with AFib and dementia and heart failure. AFib is easily detected by an ECG. There are proven treatments to reduce risk of AFib-related stroke. And the great thing about these direct oral anticoagulation agents, particularly my favorite is apixaban.
Hey, just so the patient can get treated.
Actually, I do, I was working at the county, actually I have a lot of patients on
I guess my
rivaroxaban.
question, yeah, well.
I just want to say that
For
we
daily dosing.
compete in this room against disease and not against each other.
Right.
We're not
Oh,
talking
yeah,
about
I didn't mean
No,
that.
no, no,
Right.
because that's what I'm saying, is at least the patient is getting
Something.
treated.
Yeah.
But we are on Medi-Cal, like you were saying.
Anyway.
Sorry.
Okay.
Okay.
Okay, this is getting treated, that's amazing.
And it's better than warfarin, all of them are better than warfarin. Okay, so the cons is that we lack randomized controlled data for the causal relationship between subclinical AFib and stroke. We have yet to know if AFib screening in fact reduces the incidence of stroke, and we have yet to find the optimal combination of AFib screening testing, the strategy, and really the most important thing to take away from this talk is the target population. So I've listed several studies here that have done atrial fibrillation screening in adults 65 years of age and older. And that's often a common cutoff because then you start to get a minimum risk, annualized risk of stroke around 2%, depending on the inclusion criteria. And there's lots of different ways of screening for AFib in clinical practice. The most popular one the biggest one that was done in the UK was just using a 12-lead ECG or pulse check in the office. That was a SAFE trial. The Search AFib trial was done in the same age group, but in a pharmacy setting in Australia using Cardi Mobile. The mSTOPS trial was done with a Zio patch. They distributed Zio patches remotely through using the Aetna database, and people wore it for a mean amount of time of 12 days. StrokeStop used another single-lead ECG called Zenicor, which looks like a Nintendo Game Boy that you hold in your hands, that you would use twice daily for 2 weeks. And then finally, the Rehearse AFib study used Cardi Mobile and did twice weekly ECG recordings for up to 12 months. So there's been all these different ways of slicing the cake. And typically what they found is that the incidence of new atrial fibrillation diagnoses is about 1.5%. So it's rather low when you think about it. The longer you go, for example, with the Rehearse trial up to 12 months, they detected about 4% new cases. mSTOPS was also about 4% at 4 months. I think it was like 6% at 12 months. There are heaps more research studies that have been published using Cardi Mobile for screening in different care settings. So Kaiser San Diego has done a trial where everyone coming into a primary care clinic when they were getting their vital signs checked took an ECG with Cardi Mobile, and they also detected 1.6% new AFib cases. Hong Kong has done these systematic community-wide screening in patients 18 years of age or older. They did one study with 13,000 patients and found new AFib of 0.8%. Another strategy is to screen people when they're getting their flu vaccine. And that was in Australia with an AFib detection of 0.8%. So the whole premise here, using Cardi Mobile or another ECG device, is that you pick a target population that's enriched enough with a prevalence of AFib that you think is reasonable, but also, at minimum, if you do detect it, they would be eligible for blood thinner therapy according to CHADS 2 VAS score. And it also balances the risk of having a false positive diagnosis on an ECG. And you would use some type of screening mechanism. So here we have a booth, and I can describe it a little bit later. It's called the screening station. You put your fingers on the device, and you would get a recording that would tell you if you had atrial fibrillation or not. Your doctor would look at the risks and balances of starting anticoagulation versus your risk of bleeding. You'd be prescribed anticoagulation, and then anticipating that your risk of ischemic stroke would be reduced. So there are some back of the envelope calculations you can make using absolute risk reduction and your knowledge of the incidence of a new atrial fibrillation diagnosis based on the studies I mentioned. The number needed to screen to prevent one stroke really varies on the target population. So if you just look at all 65-year-olds, you would need to screen nearly 13,000 patients to prevent one stroke. So it's definitely sobering. You need to think about how you would do this in your hospital or even in community, the number of times you would have to treat someone with a blood thinner to in fact reduce a stroke. And it actually makes it quite challenging to conduct research and actually have the power to significantly detect stroke reduction when you're doing these screening studies. And then even if you enrich the population to being 75 years of age and older with an additional risk factor like diabetes or hypertension, you need to screen 650 patients to prevent one stroke. So what do the guidelines say for subclinical AFib or silent AFib? The European Society of Cardiology, the same societies in Australia, New Zealand, and Korea have class 1 recommendations for doing a pulse check or a single lead ECG strip in patients 65 years of age and older. You may have heard that the U.S. Preventative Services Task Force came out in the fall with the letter I, that there was insufficient evidence to assess the benefits and harms of AFib screening. So we are currently at odds with Europe as they proceed forth with doing systematic nationwide AFib screening.
So pulse check, is that a clinical pulse check?
Yes, it would be a nurse or physician
Okay.
doing this. And the reason behind doing the pulse check is the SAFE study using nearly 15,000 patients. They all included an arm for pulse check, and there was no significant difference between a 12-lead ECG and a pulse check. I find that hard to believe because, lots of people have irregular heart rates, whether it's sinus arrhythmia or it's a sinus rhythm with premature contractions or ectopy. I find that very, very hard to believe, but that's how it worked out. They must have been very good pulse checkers in that study. The evidence for cryptogenic stroke is much stronger. These folks already have a higher risk for having recurrent stroke because they've had a stroke. And so the AHA, HRS, those are US groups, cardiology groups have said, do long-term, non-invasive, and then subsequent implantable ECG monitoring with a loop recorder. Europe also says the same. And then a few weeks ago, the AHA, ACC, so the cardiology group, the American Heart Association, wrote in their updated guidelines for atrial fibrillation management that a role may exist for smart, worn or handheld Wi-Fi enabled devices with remote interpretation, citing some of the research that has been done using Cardi Mobile, including the Rehearse AFib trial. So it was a little kind of boost that there's something to consider, the value of using non-traditional remote ECG devices for detecting atrial fibrillation, but again, the randomized controlled trial evidence is not yet there. Okay, so the traditional options for AFib detection quite vary from a single point of care, whether that's a pulse check, 12-lead ECG, Or you might do a Holter, which is the most common type of ambulatory ECG monitoring in the United States. About 60% of all ambulatory ECGs are 2-day Holters. Then you have a 2-week cardiac patch like the Zio patch, which is continuous ECG monitoring. Once you get up to 1 month of ambulatory monitoring, there's all different varieties of intensity. You can do a continuous ECG recording using something called MCOT. It can be episodic recording with a loop monitor. There's a whole mishmash of different options. But then there's this basically white gap, this white space between 1 month of monitoring and then upwards of 3 years with this implantable loop recorder. So enter the new day. Today's options for AFib detection now span basically point of care all through weeks to years of recording, and it's not just prescription only. Now we also have direct-to-consumer products and importantly non-regulated products as well. So I'll go through some of that now. Well, first with the timeline. So you'll see with the point of care, you have different ways of detecting your pulse or your ECG, and you'll notice that you can use your smartphone, you might use a device, or you might use a wearable. And that's the same with the weeks to years monitoring. It might be an unregulated app on your phone, it might be an FDA-cleared device like Cardi Mobile, it might be an FDA-cleared wearable like the Apple Watch Series 4. So if you are reviewing a patient or as a user yourself, what screening modalities are clinically validated, which ones are accurate, you should ask yourself, how does it work? Is it FDA cleared? Is it over the counter or prescription only? Can I see the data? Can my doctor see the data? What's the clinical validation behind it? And what are the costs to the patient and the practice? So I'm here on behalf of Cardi Mobile. We have a single lead smartphone-enabled ECG that's about the size of a stick of gum, which we can show here.
We can pass this around, but I'm not going to pass around
Yeah.
the phone with it. It's too complicated, but you can see how small it is and easy to carry. That can go on your keychain.
We have a station here that I can pass around. We'll do that right now.
Yeah. Let me get that set up.
Fortunately, I locked it, so.
How many seconds?
30 seconds.
60. Look at it. It's that. Toggle. We'll get you 60 versus 30.
Pardon?
30 seconds versus 60 seconds.
There's an option in the app. You can go between 30 seconds and 5 minutes. So the standard is 30 seconds. So this is a screening app we have for offices. It basically has like a chain so that like people won't run off with your phone. But basically what you'll do is put your fingers on the back. You just do 2 fingers. You can rest this against your hands or your chest, and you'll see that it take a terrible one.
Because you're holding it up.
You're not supposed to be talking while you're doing it.
The
It's
problem
gonna be
is,
false reading.
the way this is set up, you have to be close to the microphone, so you have to make sure it's. Anyways. You can play around with it.
You just hold it like this. You don't have to put it on a table. But you have to have
I'll
it
let people
near,
go around with
like
this.
within 3 to
So you just
6
put
inches of
these
your
2
phone.
You just, yeah, it could be 1 or 2, it doesn't matter, but different hands. Yeah. And when it goes through, it might ask you for like an ID, just put in a number and then just press next. It's not keeping track of anything. Okay. Okay, so the single lead ECG is similar to lead 1 of a 12. Oops.
It's similar to lead 1 of a 12-lead ECG. And then on top of that, we have instant analysis that will tell you if you are in a normal sinus rhythm, atrial fibrillation, or if you are, for example, tachycardic or bradycardic. If your heart rate is above 100 or below 50, you will get an unclassified recording. If you have a very wide QRS, like a left bundle branch block, you will also get unclassified. So there's a bunch of reasons why you can get unclassified. We have a portal for physicians that we use in practices where they can bill for remote patient monitoring services using the device, and they have a portal they can go in and review the data. We're the most clinically validated digital health solution on the market. We have over 70 peer-reviewed articles. You can